This is Brian Wood from University of Washington. In this National HIV Curriculum mini-lecture, I will review a recent update to the Department of Health and Human Services Perinatal HIV Guidelines. These guidelines offer recommendations for use of antiretroviral drugs to reduce the risk of perinatal transmission of HIV, and the most recent major update occurred at the end of January 2024. This is where the guidelines can be found, including the most recent updates. Please see the link at the bottom of the slide. And these are two major updates on choice of initial ART regimen during pregnancy. First, for an individual who is pregnant and has never before received ART, bictegravir TAF-FTC is now listed as an alternative option. As you'll see on the next slide, dolutegravir with 2 NRTIs is still the preferred option during pregnancy, but this shift of bictegravir TAF-FTC to alternative is a significant change. In previous versions of the guidelines, bictegravir TAF-FTC was categorized as insufficient data. Since the last iteration of the guidelines, though, there have been new published data on pharmacokinetics of bictegravir during pregnancy, and there have been more reported cases of bictegravir TAF-FTC use during pregnancy, and the accumulation of data has been reassuring. While bictegravir levels might drop some, especially late in pregnancy, the levels seem to remain effective, and with good adherence to the regimen, it does seem to be an option with a high likelihood of success during pregnancy, including in the 3rd trimester. Clinical experience with the drug is growing, and again, the data has been reassuring and has not raised any safety concerns. Therefore, in my opinion, I think it is a reasonable option to consider if someone has never taken ART before, they are pregnant, and especially if they would benefit from receiving a single pill daily option. Additionally, if someone is already taking bictegravir TAF-FTC and they become pregnant and they are tolerating the regimen well with a routinely suppressed viral load, I would have a conversation about the guidelines and about options, but I would be comfortable continuing bictegravir TAF-FTC during pregnancy if that was their preference. The other major update, which is summarized in the green box on the slide, is that ritonavir-boosted darunavir with 2 NRTIs, which was previously listed as a preferred option, now is listed as an alternative except in one particular situation. That situation would be an individual who previously received cabotegravir for PrEP and later acquired HIV. In that case, there is a risk for integrase resistance because of the cabotegravir exposure. So in that setting, an integrase inhibitor anchored option is not preferred. Ritonavir-boosted darunavir is preferred, at least until genotype resistance testing rules out the presence of integrase resistance-associated mutations. So this is in line with the adult and adolescent antiretroviral treatment guidelines and is a reminder to always ask about prior PrEP use and possible prior cabotegravir exposure in anyone who is found to have HIV, including individuals who are pregnant. Here is a summary of the preferred initial ART regimens during pregnancy. This list focuses on options for a person who is pregnant and has never before received ART, but it also gives a nice summary of the preferred options even for individuals who are taking other therapy and want to know about regimens that have the most data during pregnancy. So when a person becomes pregnant, taking a different regimen, I usually have a conversation about how they are tolerating their current regimen. I make sure it's not one of the regimens on the list of options that are not recommended, which we will come back to. I counsel about the options with the most data and clinical experience, and then the pros and cons of continuing their current therapy or switching to one of these first-line options. Again, the preferred options are all dolutegravir anchored and include dolutegravir plus 2 NRTIs, as you can see listed in the first 2 rows of the table. And then in the last row at the bottom, you can see again a summary of the ritonavir-boosted darunavir options and the situation I described in which this would be considered preferred. Here is a list of the alternative regimen options, again focusing on options for individuals who are treatment naive. So that could be someone who is pregnant and has never before received antiretroviral therapy or is pregnant and newly diagnosed with HIV. You can see again that bictegravir/taf FTC is now on this list of alternatives, and you can see others on that list. The NNRTI doravirine and regimens that include doravirine are listed as insufficient data. There simply are not enough efficacy or safety data for doravirine during pregnancy for there to be a clear designation as preferred or alternative yet. These are ART regimens not recommended during pregnancy, and I want to emphasize and give you a reminder that cobicistat boosted options, especially cobicistat boosted L-vitagravir, are not recommended because levels of the drugs decrease significantly later in pregnancy, and this has been reported to lead to virologic rebound and virologic failure, including virologic failure with new drug resistance in some cases. Long-acting injectable cabotegravir/rilpivirine is on the not recommended list due to insufficient data regarding efficacy and safety during pregnancy, and we'll come back to a few more points about that. And the options listed in the bottom row are not recommended for individuals with HIV as an initial regimen during pregnancy, and I would not offer these to a treatment-naive individual who is not pregnant either. But the point here is that if a person becomes pregnant and they have treatment experience and they have resistance-associated mutations, then these drugs could be considered. In that situation, the most important factor for preventing perinatal transmission is crafting a regimen that will effectively suppress the viral load and maintain virologic suppression during pregnancy. So in that setting, these salvage ARVs may be necessary and could be considered. Now, long-acting injectable cabotegravir/rilpivirine is becoming more common in clinical practice, and the perinatal guidelines make a few points about this long-acting injectable therapy. As I mentioned before, there are insufficient efficacy and safety data to recommend long-acting injectable cabotegravir/rilpivirine during conception or pregnancy. So if a person is receiving this combination and wishes to become pregnant, one consideration would be stopping the long-acting injectable therapy and switching to a preferred oral ART option. And the guidelines make the point that if that's done, and if the goal is to avoid cabotegravir and rilpivirine exposure during pregnancy, then ideally a person should stop that combination at least a year before conceiving, because the drugs have a long half-life and it may take at least a year or sometimes even longer for the drugs to completely wash out of the system. So in that scenario, if that's what an individual opts for, they would stop the long-acting injectable therapy at least a year before trying to conceive, switch to a preferred oral ART option after stoppage of the injectables, and it would be important to make sure that the viral load remains suppressed after transitioning to the oral therapy. That said, the reality is for some individuals, injectable cabotegravir/rilpivirine is really the best option for adherence and for maintaining suppressed viral loads. So the other important factor to consider is for some individuals, transitioning to oral ART may raise the risk of missed doses, may raise the risk of virologic rebound, and may actually be riskier than continuing the long-acting injectable therapy. So this is a situation in which I think shared decision-making is really critical, and the most important thing is to help individuals understand what is known and not known about the long-acting injectables during conception and pregnancy, and helping to individualize decisions and helping ensure individuals receive the ART regimen that they are most likely to be able to adhere to and that will be most likely to maintain virologic suppression. Because again, that is the most important factor for reducing the risk of perinatal HIV transmission. The guidelines include a section on PrEP, including PrEP, periconception, antepartum, and postpartum. And I'll just emphasize here, the guidelines still say that the preferred PrEP option during pregnancy or during infant feeding is TDF-FTC as a once daily oral tablet, because that is the option with the most efficacy and safety data, particularly for individuals who have receptive vaginal sex. The guidelines also give a reminder to register with the Antiretroviral Pregnancy Registry and to report cases in which individuals become pregnant while taking ART or PrEP. And I wanted to provide this reminder to clinicians because it is an important way that we get data on the safety and efficacy of ARV options during conception and pregnancy. So I would strongly encourage all clinicians to do it and to go on there and report instances in which your clients or patients became pregnant. You can list the antiretrovirals they were taking and any identified safety concerns that arose. And again, this is a critical way in which we learn about the safety of options. And the guidelines committees do use that data for future updates and categorization of the ART regimens. I've done it before and found it to be quite easy. Now, the recent perinatal guidelines update also includes some changes to align with the adult and adolescent antiretroviral treatment guidelines, including updates to the definition of virologic failure, updates to the recommendations for CD4 count monitoring during pregnancy, and I'd refer you to the guidelines to review those changes. If you care for people with HIV type 2, please also note that bictegravir was added to the list of recommended ARVs for treating HIV-2 infection during pregnancy. Now, this update about infant feeding is not brand new. There were significant changes and updates to this section back in the spring, but the section was reviewed and updated again, and we haven't previously summarized it on a National HIV Curriculum mini lecture, so I wanted to go through it today. I think these updates are really critical, and it's important to review this section and also to disseminate the changes and the major updates to anyone helping care for pregnant individuals with HIV. So to summarize the major points in the guidelines, all people with HIV should receive evidence-based, patient-centered counseling to support shared decision-making about infant feeding. That counseling should begin ideally prior to conception or as early as possible in pregnancy and should continue throughout pregnancy, with the goal of helping an individual understand the options, helping them understand the importance of viral suppression for reducing the risk of transmission, and helping them make the best decision for them around infant feeding. Now, replacement feeding with properly prepared formula or pasteurized donor human milk from a milk bank eliminates the risk of transmission, and everyone should be informed about that option. Achieving and maintaining viral suppression with ART during pregnancy and postpartum does decrease the risk of HIV transmission through infant feeding, whether it's breast or chest feeding, to less than 1%. Additional important points from the guidelines: if a person is not taking ART or their viral load is not suppressed, then replacement feeding with formula or banked pasteurized donor human milk is what's recommended. However, if a person is taking ART, maintaining a suppressed or undetectable viral load, and they choose to breastfeed or chest feed, providers should support the decision, should work with them to create a plan for infant feeding after delivery, and should spread the message to other providers and staff on the team helping care for that person that this is the plan and that it should be supported. Engaging Child Protective Services or similar agencies is not an appropriate response to infant feeding choices for an individual with HIV. And the National Perinatal HIV Hotline is available for questions about infant feeding by individuals with HIV, and I'd encourage you to use this resource. It's an excellent free consultation service, and if you have cases where you have questions about this and about the new guidelines, I would encourage you to reach out to them. To summarize, the preferred and alternative ART options during pregnancy have been updated. They reflect growing data for bictegravir TAF-FTC during conception and pregnancy. Additional updates were made to align the perinatal guidelines with national PrEP guidelines and with the adult and adolescent antiretroviral treatment guidelines, and the updates in infant feeding are significant and notable and critical to disseminate to clinicians and staff.
The production of this National HIV Curriculum Mini-Lecture was supported by grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA Program and do not necessarily represent the official views of HRSA or HHS.